You can go live now.
Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges and management options. For this webinar, today we have with us our guest speaker, and I would like to take a moment to introduce them. Today, we have with us Dr. Pramod Jog. Dr. Pramod Jog is a pediatrician and neonatologist from Pune and has an experience of 38 years in this field. Dr. Pramod Jog is a professor of pediatrics at Dr. D.Y. Patil Medical College, Pune. Also, he was the ex-president of Indian Academy of Pediatrics in 2016, ex-standing committee member of International Pediatric Association and ex-steering committee member of Gavi. Dr. Pramod Jog practices at Jog Children's Clinic in Pune, and he completed his MD Pediatrics from BJ Medical College in 1985 and MBBS from BJ Medical College in 1981. So with this introduction, we will start our today's webinar for the same. I'll request sir to do the presentation. Over to you, sir.
Thank you, Manohar, for those kind words. And today we are going to discuss about influenza and what are the challenges in dealing with influenza. And this is a very interesting topic, and I'm sure our listeners would definitely enjoy getting the new information about the new developments in this particular field. Why this particular topic has been chosen is for some important reasons. See, this particular disease, influenza, which in short we call as flu, has started showing, some changes in the virological structures. I remember my teacher telling me that there are some viruses which are very naughty viruses, and influenza is a naughty virus because it changes its structure. And these are the RNA viruses. Our COVID, the one which, troubled us for almost 3 years and is making its presence again in some parts of our country. That also is a naughty virus. That is because it's an RNA virus, and all these RNA viruses, they change their structures. So we come across mutants and so on and so forth. And we know that every year the influenza vaccine has to be changed because the structure of the virus changes. Okay. And we are witnessing the epidemics of H3N2 in different parts of our country, all across the country. And I will tell you, recently I came across one small little daughter who came with her mother, and I was just examining her. And this particular daughter of that mother, she was speaking to the doll which was in the hand and saying, don't worry, you will improve. It's viral. So she was consoling the doll. And I was laughing at one end. But then the another thing that I realized was that the viral infections are not that simple now. And when I say it's viral, so many viruses come at the back of my mind, like the influenza, the parainfluenza, the adenovirus, the RSV, the human metapneumovirus, and so on and so forth. And our COVID is always at the back of our mind. So the point is that over last few months, particularly after June and July last year, when the COVID pandemic we thought is probably waning off, we have seen waves of different viruses. And initially, I remember in the months of July and August, we witnessed that hand, foot, mouth disease. Okay. And children coming with, lesions like vesicles on the palms and the soles and the buttocks and the mouth. And then we had the virus like the respiratory syncytial virus, okay, somewhere in the beginning of winter. Then we had H1N1 for some period. Then we had adenovirus, which is still lingering on. And now we have H3N2. So all these waves of different viruses are making their presence. And I wonder as to why various viruses are coming up now. And for so many years, we never witnessed them. The reason probably is that during the COVID period, our children, they were all indoors. They never got exposure to the atmosphere. And all these different viruses probably were hiding themselves inside the houses. And there was no immunity against any of these viruses in the bodies of our children. And when children started getting an exposure to the atmosphere and to the school and to their friends, all these viruses have probably started making their presence. And remember, even the older children are getting affected. Probably the simple reason is that none of these kids have the immunity to combat with these viral infections. And what all we are seeing in the outpatient departments, we are observing that children are coming with recurrent respiratory tract infections. You will witness, parents coming to you, on the first of the month. You give some antipyretics and some antihistaminics. The parents are fine, happy. They say, okay, child is all right. Again on 10th, they will come back with fever, cough, and cold. Again on 20th, they will come back with cough, cold. So these recurrent respiratory infections have become very common. And probably I feel that, they have become more frequent, and the interval between two respiratory infections is also little on the lesser side. I have witnessed children with otitis media coming more frequently. So the viruses which are responsible for the upper respiratory infection, they easily pass on from the eustachian tube to the middle ear, and then children come to us at night. Again, parents complaining that the child will sleep for some time, wake up for some time, and so on and so forth. And viruses like adenovirus and others, they usually create a problem producing otitis media also. And then along with otitis media, we also have started witnessing more of adenoidal hypertrophy. Okay. And remember, my dear friends, when a child is brought to you with respiratory infections going on, off and on, then please ask them that during the last 2 weeks, how was this child behaving? So if the child is repeatedly coming, please note that there could be an element of sinusitis in some of these children, because sinusitis is the one where the cold lingers on. And when we have this lingering cold going on for more than 10 days, 14 days, then we usually put it as sinusitis. Okay, remember that. And this influenza, which we are going to discuss in details today, has shown unseasonal surge. Usually we say that majority of the parts of our country, we get influenza during the months of monsoon, and June and July and August and September are the real regular months for influenza. But during this month of March and April, we have started witnessing H3N2. And then we have adenovirus, which I just mentioned. And adenovirus we knew. And right from our residency days, our examiners took pride in asking us questions as to which is the virus which has more of non-respiratory presentations. And adenovirus was the answer which was expected by them, wherein they expected us to tell that there is pharyngoconjunctival fever. So there is pharyngitis, there could be tonsillar exudates, there could be discharge from the eye, there could be mesenteric adenitis, there could be diarrhea, so on and so forth. So more of, a virus, in addition to creating problems in the respiratory system, the one which creates problems in the systems other than respiratory system. Okay. And here we have varied presentation, and the illness is prolonged. The child is getting fever for 7 days, 8 days, and our colleagues are always, jittery. Maybe on day 3, 4, 5, 6, they, under compulsion have to start antibiotics, even though, there is no indication being a viral illness. But then this particular adenovirus is known to affect the CRP, and influenza and adenovirus are the two viruses along with COVID where the CRP is high. Otherwise, our general understanding is that bacterial infections are the ones where we have high CRP, but these adenovirus and others also have high CRP. Okay. There is increased trend of sending nasopharyngeal swabs, and there is a therapeutic dilemma. See, a child who comes to us in this epidemiological situation where not many influenza cases are going on, are we going to restrict only to the anti-flu medication? Whether really we are going to give anti-flu or not going to give, whether we are going to give antibiotics. And in this dilemma, many times we end up giving antibiotics as well as anti-flu medications to be on safer side. And let us know as to what is rational. Okay. And during last few years, whenever there was an epidemic or increase or a surge of the cases of RSV, we were many times using the metered dose inhalers and others. However, this particular season, the use of metered dose inhalers in some areas have been on the lesser side, while in some areas it has been on the higher side. And to some extent, there has been also a use of nasal steroids, though definitely more than the earlier years. So with that, this is a child who is Viru. Viru simply because he has a viral infection, and just see how he comes to us. So he has come to us with fever for 3 days. He has cold and cough. He was on the metered dose inhaler since 4 months. He was well controlled, and he has been given symptomatic treatment, but he has come back after 3 days. As I told you earlier, he has been febrile for a day, and there is a fever again. But in between, he has been always active. We all know that in viral infections, as soon as the fever comes down with paracetamol, the child starts playing, and the mother says, now he is back to his original self. But in bacterial infections, we all know that the child gets high fever. He has follicular tonsillitis. He has a tender cervical node. And even after you give paracetamol, the fever coming down, child is not his usual self. Mother says that iski tabiyat kuch pehle jaisi nahi hai. खाना नहीं खा रहा, सुस्त है, बड़े भाई से झगड़ा नहीं कर रहा. So all those things, they go on, and these are bacterial infections, and we all know that viral infections are generalized. So in the same system, the child will have runny nose, he will have cough, he will have redness of the eye, some of them will have rash, some of them will have diarrhea. More than a system is involved. But bacterial infections, the infections are localized. So the child will have follicular tonsillitis, mean only follicular tonsillitis. He won't have pneumonia. Okay. So these are localized infections which are bacterial. So in this child, one who has come to us for cold and cough, and you have given symptomatic treatment, what will you do? Remember, these recurrent viral infections have become more frequent and at shorter interval. And please keep away from giving antibiotics. Okay. Provided this particular child has mild fever and most of these symptoms which are like a viral fever. However, parents are to be counseled, because they cannot be simply just told that this is viral, don't worry. Then they will start asking you why this is happening. Every time, Dr. Jog, we come to you, you just give some medicines and the child is fine for the next 6 months. Is baar aisa nahi ho raha. So remember, please tell them that probably COVID has changed the behavior of the viruses, the structure of the viruses. Okay. And for certain viruses like adenovirus, please tell them that this particular virus, adenovirus, has definitely rather changed its behavior, and it is taking long time for the fever to settle. In my own experience, adenovirus usually fever clears off in 7 or 8 days. Okay. Influenza, of course, clears little earlier, but adenovirus, the course is a bit prolonged. And we have seen children who are going on with fever on and on, almost up to 2 weeks. So what I do is, to be on safer side, I tell the parents, see, the problem is going to take 3 weeks. Okay. And when the child improves within 2 weeks, okay, then the parents are happy. Oh, you already said 3 weeks, but because of your treatment, it has now rather come under control in 2 weeks. So we have to somehow or the other counsel the parents. But please see that the parents are convinced about the different viruses. Please tell them that children were not exposed to these viruses for almost 3 years. They don't have the immunity, and that's why they are getting it repeatedly. Now you must know as to which virus and which bacterium affects which part of the respiratory system. This is very important. Now, for example, when you have a rhinovirus, usually it will attack the nose. Okay. When you have tonsillopharyngitis, 70% of these cases are viral, and 30% are the ones which have the group A beta hemolytic streptococcus. And when it comes to sinuses and middle ear, in almost all 70% cases, it is bacterial, and 30% cases, it is viral. And in general, remember, the pneumonias are also, in majority of the cases, are viral. Okay. However, we know that the pneumococcus and H. influenzae and the moraxella are the 3 bacteria which attack the lungs. And these are also the bacteria which attack the respiratory system and produce tonsillopharyngitis also. Now, the point is that you must be able to identify the enemies, because every patient, you are not going to do the nasopharyngeal swab to diagnose what is the enemy like. So if the onset is with cold and sneezing, for example, the child has common cold, upper airway involvement without or a very mild degree of fever, and the child is playful, not exhausted, then you can think of either influenza or parainfluenza or a respiratory syncytial virus or a rhinovirus, as I said. Along with these symptoms, however, if the child has high fever, the child has headache, muscle pain, and extreme weakness, then please suspect flu. Remember, these days, when epidemiologically we have flu around, you are fully justified in giving antiviral medication like Oseltamivir in the first 48 hours, provided the child comes to you with fever, with chills, headache, muscle pain, and extreme exhaustion. Okay. I told you that adenovirus, presents in a bit of a different way with pharyngoconjunctival fever and diarrhea, mesenteric nodes, and hemorrhagic cystitis, and takes little longer for the fever to settle. In a child who is under the age of 1 year, we have always seen bronchiolitis because of respiratory syncytial virus. And if the child has fever and more of lower respiratory involvement in the form of dry cough or maybe loss of sense of taste and smell, then it could be COVID-19. And it comes to bacteria, then if you have fever, follicular tonsillitis, and a tender cervical node, think of streptococcus. If the child has fever and grunting like and mother says during the night time he was continuously grunting, like in Hindi you say karana, no kararata, so that particular with tachypnea, this is pneumococcus. Okay. And if there is a rapid progression and the child is toxic and within a period of 48 to 72 hours, there is progression from pneumonia to pneumatoceles and then to effusions and empyema, then that is staphylococcus. And beyond 5 years with predominant cough, we have to think of mycoplasma. Okay. With this knowledge, you can have an educated guess of what is the enemy. Okay. And I will tell you, this was the child. You can see that, he was a 4-year-old child with cough and fever, high-grade fever going on for 5 days. And this child on day 3 was put on antibiotics by the pediatrician, and he was not at all settling with oral medicines. And on admission, he had tachypnea and he needed oxygen support. If you see the X-ray, you can see that on the right side, the lungs have been infiltrated. And being in the hospital, of course, we investigated when we found that the total count was on the lower side. The platelet count was on the lower side. There was a mild derangement of the liver function tests. And in the hospital, as a protocol, we usually send the nasopharyngeal swab. And this turned out to be positive for H3N2. Okay. The type A influenza virus, which is so very rampant in the atmosphere. Okay. So this was a presentation where influenza came with low WBC count and low platelet count. Now here, my dear friends, another case, a 3-year-old child with cough and fever for again 5 days. Fever was not settling down. The counts were normal, but then the nasopharyngeal aspirate showed H3N2. This nasopharyngeal swab, usually we do it when a child is admitted, when he has severe symptoms, when fever is not settling down. Okay. And another child, similar one with 5-year-old with cough, cold, and fever with normal counts, but CRP a bit on the higher side, and the nasopharyngeal aspirate showed H3N2. And this was another interesting case where a 1-year-old child came for fever, cough, cold, status epilepticus. He came convulsing, and the nasopharyngeal aspirate showed H3N2. The counts were normal, and the MRI showed non-specific changes of encephalitis, and CSF was normal. And this we termed as influenza encephalitis. This was only to show you the spectrum of influenza cases which we have been witnessing. And a very, very common situation where, IT sector couple, comes to you with a 7-year daughter. Of course, IT sector for, all of us is not only information technology, but these are the patients who are inquisitive and troublesome. INT. Okay. So they will come in the half pants and they will bang their laptop on the table and they will start asking you questions as to what is this. Then you say it is influenza. So what do you mean by influenza? You tell them that it is a viral illness. So what is this type of virus? So you tell them that it is H3N2. So then what was that H1N1? So on and so forth. And as if you are appearing for an MD Viva, you have to answer their questions continuously. Anyway, so this 7-year daughter came with high fever for 3 days with throat irritation. And parents said that after 2 days, my daughter has an exam, and then the throat was showing mild congestion. And I prescribed paracetamol with the flu and the adenovirus around. The real question is, what do I do? Whether I give empiric Oseltamivir, but my dear friends, remember that when presentation is of this nature, where there is mild congestion of the throat, only throat irritation, please remember that there is no need to either send a throat swab in an older child. This is a relatively older child. and there is no need at this moment to give Oseltamivir. However, if you see another boy who came, 3-year-old boy with cough for 1 week, high fever for 3 days, remember high fever, and crepitations in the chest, and being treated with coamaxiclav for the initial few days, and then admitted for persistent fever. Here you have to think twice, because this child has low respiratory involvement. So whenever a child comes to you with respiratory rate which is on higher side, a child who comes to you with distress, then you are fully justified in starting Oseltamivir. Now here, what happened was, because this particular child came to us with respiratory and lung involvement, then we put this child on the IV amoxiclav, and then the counts were normal, CRP was also normal. So in fact, we had a discussion whether we should put this child on any antibiotic. But then, as you all know, that it's many times very difficult to differentiate viral from bacterial, and the child having high fever, we wanted rather to err on the safer side. And then at the same time, as our protocol says that we need to send a swab, we sent it, and it turned out to be influenza A. And I told you that Oseltamivir was added. Now, my dear friends, remember one important point, that in children with influenza, 25% of them have co-infection, okay? And pneumonias are known in 25%, the bacterial pneumonias. And that is why it is difficult to decide whether we continue the antibiotics or whether we stop antibiotics. It all depends on the presentation of the child. So if the child is really unwell, if the child is really sick, now the word sick is anybody's guess. But then in general, remember, if a child is not playing, not eating, not sleeping well, and his general look is like a sick child, then you can always continue antibiotics, but it's all an individual decision. The colleagues of mine, those who are working in the institutes, may sometimes only continue Oseltamivir when they get influenza A on the throat swab, while some of our colleagues might continue, but it all depends on the individual child who is in front of you. Okay. Now, today morning, this particular child who has been admitted, the younger sib, who is 8 months old, has come with high fever since yesterday. Now, what do? It's obvious that you will give him Oseltamivir, because influenza is a disease which is highly transmissible, rapidly transmissible. Incubation period very, very less. Within 2 to 3 days, the entire family can get infected. And that's why, if there has been a proved case, proved with the nasopharyngeal swab, having influenza A, then in case if there is a younger sib, you will always give him Oseltamivir. Okay. And remember that this particular point is very, very true in case of influenza. Okay. So we must know certain things about this disease, and we all have witnessed all the pandemics of influenza. By the way, KYC stands for Know Your Customer. Okay. Just in the bank, we have to submit our PAN card and Aadhaar card and so many things, so that the bank knows that you are the customer. Okay. So we should know what is this KYC of influenza. So in 1918 and 1919, okay, almost 100 years and above, we had the Spanish flu, which was, H1N1. And we all know that, in fact, that particular pandemic took a big toll, and almost 500 million people were affected, and 50 million are supposed to succumb. And then almost 1/3 of the world's population was affected at that time with influenza. Okay, that was H1N1. After that, in 1957, there was H2N2. This was a major shift. You all know, I told you in the beginning that RNA viruses, they are naughty viruses. They show continuous changes. But once in a while, there is such a change that the entire virus changes its structure, and this is a major shift. Okay, what occurs every year is a minor change, which is called as a drift, but then the major shift occurs once in a while. And in 1968, it was H3N2. Okay, so today what we are witnessing was witnessed in the form of a pandemic in 1968, and that was the Hong Kong flu. And 2009 is something which we can never forget, again, where this H1N1 novel influenza virus came, which still continues to be there in the atmosphere. So you should be aware that influenza is not something to be taken casually. You have to be very, very careful. And the challenges and the understanding of the flu is ongoing. And every time we are learning little new, and we'll see what are the complications and what are the evidences for the use of Oseltamivir and the recommendations for the use. Okay, so over last few months, we have seen so many news items showing that H3N2 virus has been linked to the high fever and the cough cases. The cold wave and the fog and the rising pollution have triggered the surge in the flu cases. We have also seen the private hospitals, starting flu screening as the number of COVID admissions rise in certain parts of our country. And flu, that's why, is not seasonal now, but it has become a perennial condition. We all knew that in case of our country, majority of the states have a problem during the monsoon, but J&K, that is Jammu and Kashmir and Tamil Nadu, have this particular problem somewhere by the end of the year. And remember, the surge in the prolonged flu-like illness in children has been there, and the viral infections are in full swing, and H3N2 infection is in the air, and the infection and the pediatric patients is being dragged. Okay, and I told you, remember some important symptoms. If there is runny nose, if there is fever with cough, and three important things: the pain in the muscles, headache, and also extreme weakness. So in case if these three are there, along with fever with chills in the initial 1 or 2 days of presentation of the child with an epidemiological background, you are fully justified in giving Oseltamivir. And the update on the seasonal influenza for ICMR in the initial weeks of this year tells you that the influenza H3N2, if you look at the middle column and the middle row, you can see that the number of cases of H3N2 have always been on the higher side as compared to influenza A H1N1 and influenza B strains. Okay, and as I told you, there are quite a few challenges as relates the healthcare. So COVID has taught us to wear masks, and all those precautions, they hold true even for influenza. So using a handkerchief while coughing, by the way, there is something called as a Dracula cough. Dracula cough is the one where you are supposed to cough in the elbow so that you are not exposing your hands to the virus, because hand is the one which we usually keep touching to different objects. Okay, so cough in the elbow. Also use a handkerchief, okay, and dispose it off properly. Wear a mask, avoid shake hands, and so on and so forth. So all those things which are connected with the alphabet H and the hand and the handkerchief, all very important. And this is true for all those respiratory viruses. By the way, the transmission of influenza is by the droplets, and these droplets, they spread inside in the air, and then that is the real cause for concern. Okay, and there were plenty of studies, particularly this is one of the studies from the Indian Journal of Medical Microbiology, where the study was done in 2019, and almost 36,000 and odd specimens were subjected to the study, and the duration was for 7 years. And influenza positivity was seen to be starting with the onset of monsoon and peaking during the post-monsoon months. And in India, this is the overview of influenza. Particularly, you can see that the cases of influenza infection and the deaths due to influenza infection. So the influenza and the related deaths are increasing alarmingly in India. And we all know that this is the virus which is most common infectious disease, which is highly contagious and occurs in seasonal epidemics and cause mild to severe illness. You remember, initially, when the child has a mild illness, you are not worried. Fever, cough, cold, mild throat irritation, the child recovers in majority of the cases. But if he goes from stage 1 to stage 2 and the child starts worsening, the respiratory rate increases. We all know that WHO has given us nice guidelines wherein a child under the age of 2 months should not have respiratory rate above 60. Between 2 months and 1 year, it should not be above 50. And above 1 year, it should not be above 40. So in case if the rate is rising, you have to be very careful. If the saturation is dropping, you have to be very careful. If you are getting crepitations in the chest, you have to be very careful. Okay. And all the three types of influenza viruses are very well known to us, particularly influenza A, influenza B, and influenza C, where I told you that influenza A is associated with frequent epidemics, and there are pandemics because of the major antigenic variations, which we call as shift. Okay, what we get every year is a minor variation, and that is a drift. Okay, and influenza B, these viruses infect only the humans and produce very local problems in the form of epidemics. And influenza C viruses, they infect the humans as well as the swine, but these infections are generally mild. And currently, the viruses which are circulating are H1N1 and H3N2. And people with flu can spread it to others for about 6 feet. And the flu viruses are spread mainly by droplets, and the droplets can land in the mouths or the noses of people who are nearby. And that's why people should stay away from the affected person and wash the hands, which I already told you. And remember, children may pass the virus for longer than 7 days. If you try to differentiate the influenza-like illness and H3N2 and severe acute respiratory illness and COVID, it's very, very difficult. And I always say that even Rajnikant cannot differentiate different viruses. Okay, he will also be puzzled as to what he's dealing with, because fever and myalgia, cough and weakness are all common to all these viruses. Okay, however, breathlessness is the one which is more common, as you all know, in COVID-19 and severe acute respiratory infections, which are associated with H3N2, and the loss of sense of smell and taste are seen in case of COVID. And yes, diarrhea we have seen in children presenting with with COVID-19, we have seen that. And headache many times is present along with influenza. So you have to remember that there are some features which favor one virus over other, but it's very, very difficult. And that is the reason why we get puzzled as to whether we should start Oseltamivir, whether we should not. And we have to be very, very careful when we take a decision. In general, my dear friends, remember that why we are worried about the flu is because the infection can spread to the middle ear, producing ear infection. It can spread to the lungs, producing pneumonia or ARDS. And many times it can create a problem, as I told you, in the form of encephalitis and others. So it's not a very, very benign virus. And that's why when we manage it, in the mild variety, we can simply advise the parents to give bed rest and have more of fluids with cough suppressants and lozenges and some non-steroidal anti-inflammatory drugs for fever. And of course, noting the point that aspirin should be avoided, because we have all learned that the Rye syndrome, which is so very common when we use aspirin in children with influenza. Okay, so keep away from that. But paracetamol is okay. And then most of these patients who have mild influenza, they will recover in 3 days. But the weakness may persist for a long time. And the severe cases are the ones which require admission, IV fluids, and other supportive measures. And in case if you use antiviral drug like Oseltamivir, which is a neuraminidase inhibitor, okay, that's an enzyme which is there on the outer side of the influenza virus. And I will show you one of the interesting pictures. So this antiviral drug will block the neuraminidase enzyme, which is very, very critical in releasing the virion. These are the virus particles from the infected host cells. So once this particular point is blocked, then basically viral replication is stopped. And for treatment of influenza A and B, we can always use Oseltamivir. So it's a neuraminidase inhibitor, and Oseltamivir is a potent and a selective inhibitor of that neuraminidase enzyme. And it's a prodrug which is converted to the active form Oseltamivir carboxylate in the liver. And it inhibits the influenza virus replication and pathogenicity, and it prevents the further spread of infection. And it's effective against all the strains of influenza A and B, including H5N1, swine origin H1N1, and H9N2 strains. This is the picture that I was talking to you about. And you can see that in the center, we have the virion, and it is the one which is releasing new virions, creating continued viral replication. But when you use neuraminidase inhibitor, you can see a red colored cross. So that has inhibited the neuraminidase, and that's why there is no release of the virion, and the viral replication has been halted. And this was the first oral neuraminidase inhibitor, which has been approved in more than 100 countries, and it has been endorsed by the FDA, CDC, American Academy of Pediatrics, And you can always remember the dosage and the recommendations. Remember, now we have a capsule of Oseltamivir 30 milligrams. Till now, what we had was a 75 milligram capsule and a syrup. And adults are being given 75 milligram capsule twice daily as a part of treatment. Remember, when you have a high risk individual in the family, or a younger child who is under the age of 5, or a pregnant mother, or people above 65 who are at a risk of getting problems with influenza, we have to prevent influenza, and that is the chemoprophylaxis, where treatment is given only once daily and it is given for 10 days. Okay, and syrup of Oseltamivir contains 12 milligrams in 1 ml. Now, in children who are under the age of 15, under the weight of 15 kg, you have to give 60 milligrams. Now, it's very difficult to give a 75 milligram capsule, break and all that can be done, but then you have to give 60 milligrams. So you can conveniently give 30 milligram capsule, 2 capsules, particularly divided twice daily. So if you want to give 60 milligrams per day, you can give 1 capsule in the morning, 1 in the evening as a therapy. And if you want to give it to the contact, you can give 30 milligrams once daily. If is a child about 23 kg, you have to give 120 milligrams in a day. That will be 4 capsules of 30 milligrams. So you can give 2 in the morning and 2 in the evening. Okay. And if the child is less than a year of age, you can always use in the dose of 3 milligrams per kg, and you can use it in the form of a syrup. But remember that recommended duration for prophylaxis is 10 days, and the duration for community outbreak prophylaxis is up to 6 weeks or up to 12 weeks in immunocompromised patients. Okay, and the treatment with Oseltamivir should be initiated within 48 hours of the onset of symptoms. This is extremely important. When you get a child who has the symptoms like high fever, chills, and headache, and weakness and muscle pain, you are justified in giving Oseltamivir, provided there is epidemiological support. When you started, there will be definite breakdown of the fever. The child will respond like dramatically. And then remember that pediatricians always ask me, sir, what to do that the child has had fever for 5 days. After day 5, nasopharyngeal swab has shown influenza. And you always say that, sir, Oseltamivir should be used in the first 48 hours. What to do now? Remember, even if the patient presents late, please see that you give Oseltamivir, because viral replication continues. I told you that children continue to excrete the virus for a long time. And that's why you are justified in giving Oseltamivir even if the child comes late, because it has been associated with reduction in the mortality. So we also witnessed in our series that children who come late, the admission rate, hospitalization rate, complications, and the death all are reduced when we use Oseltamivir. Okay, and as I told you, it's available now as 30 milligram capsule. So if the child is weighing less than 15 kg, then the treatment dosage for 5 days will be 30 milligrams twice daily, and the prophylactic dosage for 10 days will be 30 milligram capsule once daily. So this is very convenient, and there is no wastage, and it saves a lot of money for the parents also. Okay, and there have been benefits of the empiric and the early use of Oseltamivir, and plenty of clinical trials which tell that the treatment with Oseltamivir reduces the lower respiratory tract complications, antibiotic usage, and hospitalization, and also the occurrence and the severity of pneumonia. Okay, and that's why the probability of any severity of pneumonia and severe pneumonia, basically, gradually with the time from symptom onset to Oseltamivir administration, where more, but then early initiation of Oseltamivir after symptoms onset significantly reduced the occurrence and the severity of pneumonia and shortened the hospitalization during this pandemic of H1N1 in 2009. And the patients with a shorter time to Oseltamivir administration were discharged earlier. The patients were also discharged earlier, and this was a finding which was statistically significant. And WHO also has strongly recommended the empiric therapy and the treatment to be started as soon as possible. And the laboratory confirmation of influenza virus infection is not necessary for the initiation of treatment. And the negative laboratory results do not exclude the diagnosis of this H1N1, and that's why you have to give it early. And if the high risk individuals have been exposed to a patient with influenza, you have to consider presumptive treatment with Oseltamivir. The point is that you have to be convinced about the use of this particular medication when the clinical scenario presenting to you is like influenza. Okay. And an early empiric supportive therapy and monitoring also has been advocated by our government. And empirical therapy includes the neuraminidase inhibitor in the form of Oseltamivir when there is local circulation of other risk factors, including travel history or exposure to animal influenza viruses. Okay. And in adults also, there has been a recommendation where anti-influenza treatment like Oseltamivir should be prescribed for adults with community-acquired pneumonia who test positive for influenza. And Oseltamivir is associated with reduced risk of death in those patients hospitalized for community-acquired pneumonia who test positive for influenza. Okay, and treatment within 2 days, basically right from the onset of symptoms or hospitalization, will result in best outcomes. This is true for adults also. Why I'm trying to tell you is because children are the ones who spread the disease to the adults. COVID usually spreads from adults to children, but in case of influenza, children are the ones. And in the family, you can have a father who is a diabetic, a mother who has asthma, a grandfather who is probably on steroids for some chronic disease, and so on and so forth. So it is quite likely that influenza will take a different turn in the adults, because once the children spread the disease to the adults, they are at a higher risk. And that's why, my dear friends, remember that the pattern of influenza this year has been a bit early. It's unusual, and it's H3N2 along with influenza B, and the proper diagnosis and the early treatment can prevent the flu complications. Okay, and the empiric use of Oseltamivir will reduce the lower respiratory tract complications, the hospitalization, and antibiotic use. And WHO, American Thoracic Society, and the Ministry of Health and Family Welfare have recommended the empiric use of Oseltamivir. What you should know is that many times, our colleagues, they forget about vaccination. And that is why you should also know that when a child is presented to you with these symptoms of influenza, and if there are younger children in the family, you should strongly advocate about influenza vaccine. Now, in our country, the southern hemisphere vaccine is the one which is usually advocated, just before the monsoon. So now April and May are the months where you must advocate influenza vaccine, because with whatever efficacy it has of say 60 to 70%, if it prevents influenza to that extent, that's also worth it. And that is why please see that all the children who are above the age of 6 months receive the first dose of influenza vaccine. The one who has completed 1 month after the first dose receives the second prick of influenza vaccine, and annually 1 dose every year. And this has to continue lifelong. So please follow the schedule for influenza vaccine also. And to prevent influenza, we have seen all those important points related to the alphabet H and the hand, and related to the hand washing and the handkerchief, and keeping the person at a hand's distance, and so on and so forth. Please remember that in addition to these safety measures and use of vaccine and early use of Oseltamivir, I'm sure we will be able to control influenza and related complications to a great extent. Okay, with that, I have stopped sharing the slides from my end, and there are some questions, particularly related to the current strain of COVID and fatality in the pediatric patients. Fortunately, fatalities are not noticed in the pediatric age group related to the COVID-19 current strain, though it is rather, frightening to note that COVID is making its appearance. And some of my colleagues have also witnessed some children with, cough, cold, and eye discharge, and some different symptoms. But then we do not have a solid number of children wherein we can support the observations of some of our colleagues. But then over a period, I hope that this particular rise or the surge in the COVID cases slowly goes down, and we are not faced with a situation which we witnessed in 2020, 21, and 22. But then in majority of the cases, the response to antibiotics and antihistaminics and symptomatic treatment has all been something which has been required, nothing beyond that. Okay, so with that, Dr. Manohar, in case if you have any other questions, and if there are any of our listeners who want to add any questions, please let them ask so that I can answer them. And yeah, you can also
these are the questions which are raised, so
yes,
that is how it is.
Yes.
So, sir, I think with this we can conclude that session for today's webinar.
Thank you.
Yeah.
Thank you very much. Thank you.
So, thank you, sir. Thank you so much for being on a panel and sharing your thought with us. I'm sure with your explanation, it will be very much useful and helpful to audiences. And I thank all the audience to joining you on this webinar and sticking till the end. Thank you.
Thank you.
And have a great day.
Okay.
Thank you so much, sir.
Bye.
Bye.